Thanks so much for letting me be here. Obviously, this is a topic that I'm very passionate about. It's my job that I do day to day, and it's migraine in children and teens. So, in the headache clinic here, we see all sorts of headache disorders, but migraine is definitely the most common, as most of you all out in the community and also whoever works in the inpatient side too knows really well. It's the most common neurologic disorder worldwide. So, there's a lot of people who suffer from it, and that does not exclude children and teens. So I love talking about this topic and teaching more about it. So we can um, go ahead and start. So this is my objectives. So basically, I just want to review a little bit about what migraine is, kind of the criteria for diagnosis, how we know now migraine works, and then kind of the general evaluation of someone who has migraine or is coming in for headaches. And then we'll kind of go more into the nitty-gritty of management, especially talking about new treatments that um, have been out a little bit for adults, but actually are on the very near horizon for pediatrics. So just a little bit about migraine. Like I said, it's one of the most common disorders that anyone can suffer with in the world, but the most common neurologic disorder for sure. And as you can see, it has a huge impact. And it is a neurologic disorder, but it is also considered a type of pain disorder. So it is a huge cause of disability, both in the pediatric and the adult side, causing lots of missed school, missed activities, and obviously missed work in adults. So a very important disease that we deal with, whatever, no matter what subspecialty or specialty you're in. We use something called the International Classification of Headache Disorders to classify all sorts of headache disorders, but each disorder has a specific set criteria that we look at to make sure we know, what we're dealing with and how to treat it. And that obviously includes migraine. So here are the ICHD-3 criteria for migraine without aura. And I kind of highlighted the important parts, which are at least 5 attacks, usually lasting 4 to 72 hours untreated, and then at least two of the following, which are unilateral location, pulsating quality, moderate or severe pain intensity, and aggravation by or causing avoidance of routine physical activity. And then also at least one of the following, which is nausea and/or vomiting and photo and phonophobia. And also obviously the qualifier that it doesn't fit any other diagnosis better. These parts I highlighted though are important because specifically this kind of is geared towards adults. And so in pediatrics, we do know there are some differences in how someone who has migraine can present. So in children and adolescents, it's more often that headaches are bilateral than in adults, usually frontal or temporal. We typically see a more bifrontal distribution of pain in younger kids, and as they become more adolescent, it kind of tends to move more temporal. Yeah, occipital location is not rare, so it's not uncommon for someone, a kid, to come in with headache and have more occipital type of headache. And then the attack duration can be as short as 2 hours untreated. So that's enough to fulfill that criteria. Also, as many of us can understand, getting a history from a young child is not always the most easy thing to do. So, inferring other of the associated symptoms like photo and phonophobia from behavior is also something that may need to be done. Migraine with aura is another subtype of migraine, and that basically is migraine attacks that have one of the few symptoms that are listed here, and you have to have at least 2 attacks to qualify for that. And the most common symptoms are visual, sensory, followed by speech and language and motor, brainstem, and retinal. And auras have very specific characteristics that differentiate them from other neurologic phenomena. So they tend to spread gradually over time and more than one can occur at the same time, but usually auras only last 5 to 60 minutes and then fully resolve. And that's really important to differentiate aura from a more progressive or permanent type of neurologic event. And then usually they're unilateral and positive, meaning, it's not usually a deficit in someone's ability, more so an addition of a symptom. And then usually it's followed by or accompanied by headaches within that 60-minute period. And so most commonly that we see is a visual aura. followed by sensory. So those may not be uncommon for someone to run into, and obviously is oftentimes mistaken for stroke-like symptoms, but I would say the association with headache plus the timing of the symptoms is the most important to really understand whether to be worried about a more serious neurologic disorder like stroke versus a migraine with aura. And then chronic migraine is something we see a lot, especially in the adolescent population. So chronic in this case means that headaches are very frequent, so more than half the month, and have been occurring for more than 3 months. And then obviously they have to fulfill criteria for migraine without or with aura. And then usually, for those specific criteria, 8 or more days in the 3 month per month in 3 month period has to fill it. And again, this is sort of an artificial qualifier in terms of the number that was picked, but does tend to signify a more severe presentation of the disease and possibly more issues or more medication refractory type treatment for these patients. So something important to really understand. And like I said, it's pretty prevalent in adolescents. We think anywhere from basically 1 to 2%. And we do know there are several risk factors for developing chronic migraine, including socioeconomic disadvantaged children, and that children who have chronic migraine tend to suffer a lot more quality of life in terms of missed days of school, poor performance, and then also socially, they tend to miss out more on those type of activities. Other definitions that we tend to run into a lot within the headache world is status migrainosus. So that's a migraine attack lasting more than 72 hours. Tension type headache is another type of headache disorder that is often seen not as much in children, but is a little different from migraine in that it's a more band-like whole head type of pain that is more mild to moderate. And it's not usually aggravated by activity and not usually having as many of the associated symptoms. Menstrual migraine is something very common. It's basically a headache that fits criteria for migraine that occurs in close temporal relation to onset menstruation. So it can either be plus or minus the onset or after the completion of the period. And then something kind of rare is migraine aura without headache. So we will run into that occasionally where patients have a symptom of aura that, like the definition implies, is temporary, but then no headache follows after. And then something very important to know about and to screen for is analgesic or medication overuse headache. One of the most common, if not most common, cause of a daily headache, which is basically you can think of a headache caused by the medication use itself. And typically it's associated with using acute medicines such as like ibuprofen or Tylenol more than 3 days a week, usually closer to the 5, 6, 7 days a week mark. And that itself can cause a headache apart from these other type of headache disorders. Something that we know are commonly associated with migraine, especially in younger kids, are these episodic syndromes. So they typically occur prior to the development of more typical migraine symptoms. So something I think many people are familiar with is cyclic vomiting syndrome. So that is in the ICHD-3 as well. And so these are the exact criteria for diagnosis. It's usually at least 5 attacks of nausea and vomiting that follow a very stereotypic pattern. And usually between attacks, there's complete freedom from symptoms. So that's something that a lot of younger kids will suffer from prior to developing the more typical symptoms of a migraine attack. Abdominal migraine is also another type of episodic syndrome that we see in younger kids prior to the development of more typical migraine symptoms. And that is, again, these attacks of abdominal pain, usually very nonspecific, poorly localized, but can be associated with anorexia, nausea, vomiting, pallor, and lasting 2 to 72 hours with complete freedom between attacks. Again, this is something seen usually in younger kids, and then these kids usually go on to develop a more typical migraine type presentation. All right, so next I do want to talk about pathophysiology just a little bit, just to talk about what migraine is and how it works. So We know that there's these different phases to a migraine attack. There's the prodrome, which can occur a few hours to days before, is usually associated with very non-specific symptoms. The aura phase is what we already talked about, where there's a specific neurologic symptom that occurs 5 to 60 minutes prior to the attack. The attack phase is where the headache comes. It's the most classic, what most people think of classically when they think of migraine. And then postdrome is the phase after the attack is over, but patients still have some kind of leftover type of non-specific symptoms. What this graph doesn't show is in between the prost and prodrome is what we call the interictal phase. And that's when patients are normal, where they don't have symptoms. And really, that's our job as neurologists and as any person who treats headache disorders is to maximize the amount of time patients stay in that interictal phase and maximize the time they can revert from one of these other four phases back to the interictal phase. So it used to be thought that migraine was vascular in etiology, caused by vasodilation and vasoconstriction of the meningeal blood vessels, but we found that that's actually not true. And really, the current idea behind migraine is that it's a genetic neurologic disorder of cortical hyperexcitability. So you think basically it's a disorder that involves sensitization of the cortex in patients, usually through complex genetics, that makes patients more susceptible for certain triggers that then set off a very complex neurologic response that involves the trigeminal vascular system and ultimately leads to all the symptoms that we talked about. So this is something I actually talk about with all my patients who have migraine before I ever talk about treatment, is that migraine is much more than a bad headache. Headaches are just a symptom. And migraine, I wouldn't even consider a type of headache. Again, headache is just a symptom of the disorder, and headache is a symptom of many disorders. But migraine at its core is like I said, a genetic neurologic disorder that is a cause of headaches. And yeah, at its core, it's a disorder of what I usually describe as brain hyperexcitability. And that's why we do see that people who have migraine tend to have a lot of sensitivity to stimuli in general, with or without headache, whether it's to light, sound, or smells, and whether it's to changes in weather, whether it's to bodily functions like eating, drinking, sleeping. So those are all things that we know if are off in any way can trigger a migraine attack. And that goes to point to that hyperexcitability of someone's brain that is the core of what migraine is. And again, this is just a little bit more another graph or diagram of what I've already kind of explained, where the headaches and the symptoms we typically associate with migraine are the result of the disorder, but the disorder is much more than just those symptoms. All right, so next we're going to talk about evaluation of headaches in a patient. So everyone, I think, has heard of red flag symptoms, and those are important to rule out any secondary causes of headache. So these are some things to look out for. Usually worst headache ever, young age, under 3, aura that is longer than an hour. We call that prolonged aura. Again, that gets us worried for more vascular etiology. New onset intractable vomiting, especially upon awakening. Any abnormality in neurologic exam associated with headache is a concern. And then obviously if there's any other systemic symptoms. And then some other yellow flags that can kind of get you to think a little bit more are, like we said, we talked about a new onset headache, young kids under 6, and then headaches waking up patients from sleep. If there's no family history of headaches at all, or if there's any exertional or exercise-induced headache, that's something that may not necessarily mean there's anything else going on, but something to look into more. In terms of imaging, neuroimaging is actually not necessarily recommended for every patient. I more often than not don't get imaging if the neurologic exam is normal. But things we already talked about before in terms of red flag symptoms may be a good way, within the history at least, to decide whether imaging is needed or not. I will say that for myself, the main reason I would pull the trigger on imaging is if there's an abnormality on the neurologic exam. And that's, I think what the evidence shows the most is that any sort of headache, even with all the red flags, the biggest association with that actual intracranial or secondary pathology is when there's an abnormality on the neurologic exam, especially cranial nerve abnormalities. In terms of occipital headache, I know a lot of times that is something that people are concerned about, but really, if you look at the data, there's not a lot to say that occipital headache alone necessitates any further workup. And like we had talked about, occipital location is not uncommon in pediatric patients who present with headaches. So that is not something I would typically recommend. Is I know there's always concern for a posterior fossa mass in kids who come in with headache in the occipital region, but without any other red flags or abnormalities on neurologic exam, occipital headache alone is not definitely an indication for imaging. And in terms of history, we always want to know, age of onset, where the headache is, how long, how frequent, any characteristics about the headache and associated symptoms. The course is getting worse, is it getting better? And then, like we talked about, other prodrome or aura symptoms are important. And then impact the headache, something called the Ped-Midas score, something I use a lot in Cincinnati. And basically, the Ped-Midas score really hits home on the fact that in terms of treating migraine, there's two parts. There's pain and disability. So pain is what most people are focused on, which is how do we get rid of the headache? How do we treat the headache? But disability is almost as important. And so I think important questions, even if you don't use the exact Pied-Midas survey here, questionnaire here, important things to really hit home at that I ask for every patient who comes in for headaches is, how many days of school have you missed? And, how do you feel you can how do you feel you can do at school? Do you feel like you're able to fulfill all your tasks at school to your full capacity? And it's something that I think is really important for kids. And then also asking about their social lives, right? Are you able to go out with friends? Are you able to spend time with your family? How much are headaches impacting your life in general? And those quality of life questions can really get at the core of what we're trying to do in treating these headaches, which is to help patients not only improve with having less headache days, but also make them more fully functioning, happier members of society. This is just showing how we rate the scores if you use the questionnaire. Some important parts of the headache exam, apart from the neurologic exam, is an ophthalmologic exam is very important to look for papilledema if you can, and then TMJ disease or any sort of jaw tightness or pain is important to evaluate for as well. Looking for any signs of dehydration or sinus disease are important to understand if there's any potential triggers. Hypermobility is often associated with migraine, so it's just kind of something neat to note if they have hypermobility. And then any sort of muscular tenderness, especially in the shoulders and neck, is often associated with migraine. All right, so now we're getting into treatment. So I always divide treatment into three parts: acute, preventive, and then healthy habits. And so I think that's an easy way for patients to understand how to go about treating their overall migraine disorder. So in terms of acute treatment, the pearls I always talk about are treating early. It's always important to treat at onset of the attack. Always using the most effective dose, the highest dose possible, which oftentimes does go over the recommended dose that we think of, especially for patients looking on the bottle. For younger patients who can't swallow pills, always obviously looking at liquid or non-oral options. And then the faster acting acute medicine is, the more likely it will be effective. So we always, in terms of acute treatment in pediatrics, start with the NSAIDs. NSAIDs tend to work better than analgesics like Tylenol or acetaminophen. So I almost never recommend acetaminophen. I also don't eat in adolescents, not so much in younger kids, but almost never recommend something like Excedrin or Fioricet, which I know used to be favorites. But mostly because of they contain caffeine, and then Fioricet contains butalbital. So NSAIDs, from their anti-inflammatory nature, we know tend to work better to treat migraine attacks. So we always start with those, and we use a 10 mg per kg dosing. You can repeat. We allow short-term repeat of the acute medicine, and again, that's getting at the idea that we want to treat the attack early on as effectively as possible. But then we limit the use to 2 times per day, and then no more than 3 times per week, 3 days per week, to again avoid that risk of medication overuse. Triptans are a good treatment for the more moderate to severe attacks. So how I stratify my treatment is if you have a more mild attack, reach for an NSAID. For severe attacks, I tend to add a triptan on. And here's a list of all the triptans approved in pediatrics. Rizatriptan is the only one approved 6 and up. The rest are 12 and up. And we usually use dosing of 2 to 4 times per week. 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 2 to 4 times per Less than 30 kilos is the lower dose, and more than 30 kilos is the higher dose. But we don't, you can repeat a triptan 2 hours later, but we don't want more than them use more than 6 to 8 days in a month. And then there's lots of evidence that at this point shows that the combination of NSAIDs and triptans are the most one of the most effective ways to treat a severe attack. So that's usually what I recommend as well. Is if someone knows they have a severe headache coming on, or a severe headache has already happened, go ahead and take both the triptan and the NSAID together. Side effects of triptans are usually drowsiness, dizziness, and this sensation of jaw or chest tightness. And we want to avoid triptans in any population that's at risk for any sort of vascular complications, such as patients who've had history of stroke or have uncontrolled hypertension. Preventive treatment is, the treatment that we start on when patients are having more frequent migraine attacks. So usually more than twice a week or 8 a month is when we start to think about migraine preventive treatment. And it's always something I stress when I talk about preventive treatment, that it's not to necessarily cure the disorder or get rid of the headaches completely. That would be great if that could happen. But migraine is a lifelong disorder. It's genetic. It's just how someone's brain is wired. So usually I say the goal is to reduce the burden of symptoms, and we always want to use the lowest effective dose, but we titrate up slowly. And you usually want to wait at least 6 to 8 weeks before understanding whether medication is going to work or not. And usually the caveat for me there is 6 to 8 weeks after titrating up to the goal dose. So if a titration, obviously takes like a month, then 3 months out is a good time frame to understand how well preventive treatment is working or not. What we also know is that a lot of patients who get better on preventive treatments can wean off. And so usually 2 months after well control, we can start weaning off the med. So it doesn't mean patients have to stay on these meds forever. Different types of preventive treatments are the nutraceuticals, which I listed here. So vitamin D, riboflavin, coenzyme Q10, and folate are common ones that we use that all have evidence within the pediatric population for use and work really well. And then, of course, there's the other medicines that I guess most people here are familiar with. So the anti-seizure meds, the antidepressants, antihypertensives, and then the serotonin modulators. So amitriptyline, I would say, is probably the most common one we use, and we use 1 mg per kg dosing. Side effects are usually sedation and constipation. And then topiramate is the most common anti-seizure med we think of. And then usually propranolol is the most common antihypertensive. Superheptadine is very nice in younger kids who need medication besides tablet form, something more liquid. But usually kids outgrow its use as they get older and bigger, just because the sedation side effect as the doses go up get more significant. Botox is a great treatment for chronic migraine. It's actually not technically approved in children, but almost always we get it approved as long as they meet criteria for chronic migraine and have failed other preventive medications. It's 31 injections, and I would say teenagers do tend to tolerate it well. I have a fair bit of young adult and teenage patients who do it, and though we don't understand how it fully works, we assume it's the analgesic effects in the trigeminal vascular system that we're targeting. And there's lots of evidence to show that it is effective in the pediatric population in treating both frequency and disability for chronic migraine. Lifestyle factors, so healthy habits is the last part of treatment that we tend to look at. So I always break down to eating, drinking, sleeping, exercise. So usually recommend at least 64 ounces a day, limiting caffeine intake. Usually in pediatrics, I say no more than once a week. Any amount of moderate to exercise a few days a week. Eating a balanced diet and not skipping meals. Skipping meals we know is one of the most common triggers for migraine attacks. So I always stress not to skip meals, especially in my teenage patients who like to skip breakfast. Sleeping at least 8 to 10 hours of sleep at night, a little bit more if they're younger. And then keeping track of headaches is important just so that we have some sort of semblance of objective data in terms of frequency and duration and severity. And I find that patients who keep track of their headaches with the diary tend to be the ones who I find improve the most quickly, because they can really see and understand more about their disorder, more about their triggers, more about what works and what doesn't, and how to go about changing the way they operate to help treat their disorder. All right, and to finish us out, I do want to talk about newer treatment options. These, again, aren't yet approved. Most of these aren't approved in pediatrics, but they are coming. I have heard that even within the next few weeks, that one of them may be approved in pediatrics. So the first are the monoclonal antibodies to CGRP. So we know that CGRP is a potent neurotransmitter that is also found elsewhere in the body, but has a very important role in causing a lot of migraine symptoms. And so there are three injectable pens that we like. There are once a month. They're auto injectors, very easy to use, pretty well tolerated, and have very limited side effect profiles. So these work really well in terms of treating migraines, preventing migraine symptoms, and have, again, like I said, limited side effects. So injection site reaction is the most common one. And then sometimes Amave or Arunimab specifically can cause some constipation or risk of hypertension. These, again, are hit or miss in terms of approval with insurance. They typically, I have gotten many approved, and typically you just follow the same guidelines as an adult, which is failure of 2 of other preventive meds. There was a published guideline by some pediatric headache specialists about use of these in children and adolescents, and it's the same kind of what we talked about in terms of starting any sort of preventive, which is more than or equal to 8 days of headache per month, high disability score, failure to preventive meds, and usually it's more recommended in postpubertal adolescents necessarily than children who are more prepubescent. And then, of course, any risk factors that we would be concerned about for adults, we similarly are concerned about for children, and so you can kind of see those there. The GPANTs are another type of CGRP antagonist. They're small molecule antagonists, and they are usually oral, and there are both preventive and acute medications that can be used for treating migraine. And so these are also good, again, hit or miss in terms of their approval for kids, but we like these because they also tend to have fewer side effects than triptans. They aren't necessarily more effective than triptans. If you look at the studies, triptans may still be more effective in terms of treating a migraine attack, but these ones tend to be better tolerated. So the examples are Remigipan or Nurtec, and Ubrelvy and Ubrelvy are the acute meds, and then Atogepant, Qulipta is the preventive option that you take daily. And this graph is just a nice summary of how all these molecules work. And then the last part is these neurostimulation devices. Just to wrap it up, Nerivio is a REN device that works really well. It is approved in 8 years and up, and is an armband that patients can use to treat both acute and preventive. And it's very similar to a TENS unit, as you can see here. And there's also non-vagus stimulation called the Gamma Core, is approved in 8 and 12 and up, also can be used for acute and preventive. And then something that I am a big component of is including or taking into consideration the preferences and perceived quality of the treatments offered. So I always give my patients options when they choose treatments, whether it's 2 preventives to treat from, different acute treatments to choose from, just because we know that that's very important in terms of having a patient get better. So that patient-provider relationship, as most of us know, is so important to patients getting better. So I think that's even especially true in something like migraine, which is a pain disorder. Having that buy-in and having that autonomy with their choices and treatment does go a long way towards helping them get better. All right, here are my references, and I'm open to any questions. Thanks for letting me talk.
All right, Dr. Gong. When are migraines considered well controlled to initiate weaning off preventative medicine?
Yeah, that's a great question. I would say kind of the political answer is whenever the patient feels like they are doing better, which can be, very subjective. But in general, the goal I always shoot for is less than 1 headache a week. So
Okay.
less, 3 or fewer headaches per month is when I usually start to really consider weaning off a preventive treatment.
Okay, and how is genetic inheritance explained in migraine occurrences in the family?
Yeah, so that's a really good question. I don't know if we have the best answer for it. We do know it's probably polygenetic, like a lot of other neurologic disorders like autism. So there's not necessarily like Mendelian genetics in terms of it passing on from parent to child. We do know oftentimes it can skip generations. And in terms of severity of the disorder, There are patients who are really severe at a young age and have parents who, have one migraine attack a year. So we definitely think it's polygenetic, and there's probably lots of epigenetic factors, environmental, socioeconomic factors that play into the role of development of symptoms from migraine.
All right. Thank you, Dr. Gong.
All right, thank you so much.